Evaluation of the eyes. The eyes can give a lot of information related to the overall health of a patient. It has a lot of relationships with other body systems. The skin. Well, the skin covers the eyelid, and lashes protect the eyes. The respiratory system. Color changes are seen in the conjunctiva. If someone is hypoxic, they're going to have a pale conjunctiva. The digestive system. Jaundice, which is yellowing of the sclera due to liver dysfunction. And of course, the sight of food can stimulate our appetite and make us hungry. The cardiovascular system can be in a couple different ways. You can see fat deposits that can build up on the eyes. And of course, blood vessels you can directly visualize with an ophthalmoscope. You can see changes that can reveal hypertension, diabetes, glaucoma, intracranial pressure, and some central nervous system disorders. Musculoskeletal, of course, the eyeball. There are muscles in the eye that make our eyelids open and close, as well as move our eyes all around. Neurological. Of course, the cranial nerves. You have two that's responsible for vision. You have cranial nerves 3, 4, and 6 that are responsible for the movement of the eye. And cranial nerve 5 conveys sensory data from the cornea. Cranial nerve 7 helps close our eyelids. Of course, the reproductive system, pleasure selection. Urinary, periorbital edema can indicate renal disease. The immune system, conjunctivitis, environmental toxins, allergies, and infections. The eyes can get red when you have a respiratory infection, or can tell you when you're not feeling well. Many of us look at each other and we can tell when someone's not feeling very well just by looking at their eyes. They look tired, they have bags under their eyes. Sometimes they have dark under their eyes related to sinus congestion and a lot of superficial blood vessels that are pushed to the skin surface. The endocrine system. Thyroid disease can cause changes in the eyes, and diabetes can have a lot of changes which also can lead to blindness. There are some developmental variations for the eyes. Infants, their shape, their spacing, and their vision, they are typically born with 20/200 vision. They can really only see little shadows and things directly in front of them. Vision is typically determined in infants by their pupillary response, their blink response, and their ability to follow objects. It's not unusual for infants to have a transient strabismus, and it will go away as they learn to utilize their muscles and they learn how to focus their eyes. Preschool age, they can use the Snellen eye chart. There's one with letters or there's one with shapes. Typically around 3 years old, they're 20/40. 4 years old, they're 20/30, and by 5 and 6, by the time they hit kindergarten, they usually have normal vision. School age tests, they do color blindness, and of course the regular Snellen chart. A school nurse will do this, plus a regular pediatrician visits. Older adults have all-around deterioration. And believe it or not, it starts around 40 years of age. So what do you do when someone comes into the office complaining about things going on with their eyes, either loss of vision or discomfort? You want to make sure you get all of their subjective data. You want a complete health history. And this includes anything as far as what, from contacts and eyeglasses to eye surgery or history of eye disorders. You might want to even get a family history of eye disease. Common symptoms: you have allergies, you have itchy red eyes, you have vision changes, discomfort, pain. What eye medications, if any, do they use? Have they had any eye trauma in the past or currently? Any diseases, not just of the eyes, but diabetes, thyroid disorder, liver disease. These are some of the questions that you might want to ask. About floaters, blurred vision. Do you have any pain? Itching, or do you feel like something's in your eye, something like gritty? Are both eyes affected? What about in double vision? These are only a few questions. I'm sure you can think of many more that you may have been asked during an eye exam, or can think of when you've had patients complain of eye disorders. Evaluation of the eye. So we're going to do some of our objective data. We're going to see if they're making eye contact. Are both their eyes aligned? Are they looking at us? Can they follow us? Follow our fingers. We're going to use the Snellen's eye chart, typically also called the E-chart, and then there's the Rosenbaum pocket guide. Normal vision is typically 20/20. Low vision is 20/70 to 20/200. Legal blindness is considered if somebody has 20/200 or less with correction. So 20/20 vision, what does that really mean? "20/20 means that you can see at 20 feet away what a person with normal sight can see at 20 feet away. It is very important that you actually measure 20 feet. You can only see the top E. That means you can see at 20 feet what a person can, at normal sight, can see at 200 feet. If you can read this row, you have 20/40 vision. Normal sight sees at 40 feet what you see at 20 feet. If you could read, when you are able to read this row, called 20/10, it means that you can see at 20 feet what normal sight can see at 10 feet. This means you have exceptional sight. "20" refers to that you are 20 feet away from the chart. This refers to normal sight. The bigger the letter, the bigger the letters, the bigger the number. The smaller the letters you can read on the chart from 20 feet away, the better your visual acuity is. Visual acuity is usually measured with and without corrective measures to verify that the prescription is sufficient. Another common chart you might see is the Rosenbaum chart. It's a pocket guide to test visual acuity. Other objective data that you are going to collect is the visual fields by confrontation, 6 cardinal fields of gaze, corneal light reflex, cover test, pupillary reflexes, inspection, so you're inspected for symmetry, inflammation, and exudate. You want to inspect the general appearance. The conjunctiva should be pink, moist, and without lesions. Conjunctiva over the sclera should be transparent. The lacrimal gland, palpitations, vegetation, it should not feel firm or swollen. So you're looking for excessive tearing. Did any other discharge, any unusual colors, yellow, green, or tan. The sclera should be white. Yellowing could indicate jaundice and liver dysfunction. A confrontation test is completed to check for visual fields. The person faces the examiner about 2 to 3 feet away. The person covers one eye and the examiner covers the opposite eye. This is in order to produce a baseline. Fully extend the arm out on the patient's covered side, and you're moving your fingers along the main axis, and the patient will tell you when it's first seen. Inspection. Pupils should be round, regular, and equal, usually around 3 to 5 millimeters. Patients that may have had some sort of eye surgery or trauma may not have round pupils. You're going to test the pupillary reflex to light. You could do this with your pen light. This is a direct light reflex. You also want to see that concentric light reflex. This means when you shine a light in one eye, the other eye also reacts. You're going to test for accommodation and convergence. So you're focusing on a finger that's moving closer to the nose. Accommodation, the pupils constrict. Convergence, the eyes move inward. There are things you do not want to see in a patient's eye. One of those things is called nystagmus. This is rhythmic shaking or wobbling side to side, or it could be jumping up and down. Kind of looks like dancing or jerking eyes. Ptosis is drooping of one or both upper eyelids. This could happen with certain neurological diseases such as myasthenia gravis. You may also see something like this after someone has had a stroke. Ictus sclera, also known as jaundice or yellowing to the sclera. This is definitely not a good finding. You have someone who has severe liver disease. The corneal opacity, this usually indicates cataracts. This could be a traumatic cataract or it could be one that's related to aging. Arcus senalis. This can be normal in older adults as part of an aging process. It can also indicate high cholesterol if someone has very severely high cholesterol. Cholesterol deposits can deposit and cause arcus senalis. Exophthalmia is related to hyperthyroidism, or another name for it, severe hypothyroidism, is called Graves' disease. You'll notice that the muscles of the eye become enlarged, so they pop out, and you actually see more of the sclera. The side view, you can actually see how it pops out. So we have to protect these patients and make sure they have eye drops to keep their eyes moist. Visual screening tests. Many of you had this when you were in kindergarten. Extraocular muscle function test. This is the corneal light reflex test. It assesses the alignment of the eyes. You're going to hold a pen light from about 12 inches in front of the client's face and ask them to look at a fixed point straight ahead. The cover and uncover test. This assesses extraocular muscle function. You're going to ask the client to stare straight ahead and focus at an object. They're going to cover one eye and check the uncovered eye for movement. You're going to repeat this on each side. Position test. This assesses the muscle strength of the cranial nerve function. You're holding an object 12 inches away and moving it through the 6 cardinal positions. The movement should be smooth and symmetrical. You'll notice the bottom corner, you will see someone checking this gentleman's visual field. The patient is told to stare forward, often at a fixed point behind the examiner or at the examiner's nose. Objects are moved into and around the visual fields, peripheral fields, and you're asking the patient when they come into view without directly looking at it. Ophthalmoscopy. This is the examination of the fundus or the interior of the eye. The ophthalmoscope illuminates the internal surface of the eye so the examiner sees the retina, the blood vessels, and the optic disc. In order to use an ophthalmoscope, you have to turn it on and you're going to adjust the beam of light. The scope light is on a dim setting. You don't want it too bright. You're going to set the lens disc at 0. It's at the neutral position. Keep the index finger on the lens to adjust during examination. You flip it to different fields, different lights in order to assess the different sight. If someone's nearsighted or farsighted. Approaching the patient. If you're looking in the right eye, you're going to be on the right side and vice versa on the left-hand side. You're going to hold the ophthalmoscope firmly in your hand against your bony orbit. Glasses off for both the examiner and the patient. Contacts are okay to use. You want the patient to look over your shoulder at a fixed point. Could be anything on the wall. About 15 inches to 15 degrees lateral of the patient's line of vision, shine the light into the pupil. You should see an orange glow. This is the red reflex of the retina. You're going to move on a 50-degree line toward the pupil, almost touching the patient's lashes. Some patients may need their eyes dilated in order to get a better view, but typically you can do this in a darkened room. The optic disc is on the nasal side of each retina, the yellowish orange to creamy pink, oval, or round. Follow the blood vessels centrally until you see it. So you'll notice the optic disc, and you'll notice macula, and the arteries and the veins. Clarity, it should have sharp margins, and there should be symmetry in both eyes. If you're looking at the arteries, you want to make sure there's no lesions, no red spots, streaks, or light spots. Diagnostic tests. If there is drainage, you would be doing an exudate culture, digital imaging of the eye, of the brain, the cornea, optic coherence, fluorescein. We'll talk more about that when we talk about corneal abrasions, electroretinopathy, retinography, ultrasonography, other tonometry. Most of you, if you've ever had an eye exam, has had that. It's assess the pressure in your eyes. The Amsler grid. This is another diagnostic tool. It's a grid of identical squares with a central point. The patient looks at the point and states if they see a variation in the square. This can be indicative of macular degeneration. The slit lamp. This is a way of looking at the corneal surface to identify corneal abrasions, iritis, or conjunctivitis. Tonometry. This measures the intraocular pressure. Force that is produced, an indentation is measured. So there's a puff of air that comes, and that measures the pressure. Normal intraocular pressure is 10 to 20. Anesthetic is not always used unless it's going right on the eye. Retinal angiography. Used to detect vascular changes in the blood flow through the retinal vessels. It's a water-soluble dye that's given through the peripheral veins. Special cameras are used to photograph the appearance and the distribution of the dye in the renal arteries, capillaries, and veins. Very similar to an angiography that they would do on the heart, the coronary arteries. Ultrasonography. This is for logic changes, opaque lenses, cloudy cornea, or bloody vitreous. It makes it difficult to look to the posterior eye. Very often, anesthetic is used. Therapeutic measures. You want to encourage your patients to have regular eye exams. Good eye hygiene. Washing them, not touching their eyes with dirty hands. Nutrition for eye health. There are some things that can be prevented, of course, like night blindness with proper nutrition, and macular degeneration can be decreased with proper diet. Eye safety and prevention, it's a very big thing that as nurses we want to promote safety. Wearing sunglasses, wearing safety goggles when even mowing the lawn. Eye irrigation, if needed. There's a type of eye irrigation, it's called the Morgan lens. There's guide dogs for patients that are blind. Of course, medication administration, eye patching if necessary. So eye hygiene, as I said before, we want to keep the debris out of eyes. We do not rub eyes. We want tears to produce naturally to wash away the debris. Regular eye exams throughout life. Unless there's a known problem or chronic health problem like diabetes, then it should be yearly. Typically, you can go, average adult can go every 2 years if they wear glasses. Most of these exams are covered under healthcare plans. This is an example of a Morgan's lens to irrigate the eyes. There's 2 types shown.